Hi, everyone. Welcome to our last panel of the Research Summit, which is about expanding diversity in celiac disease research and diagnosis. I'd like to invite each of our panel members to just say a few words about themselves. Nieshia, would you like to start?
Oh, gosh. Hi, my name is Nieshia Williams. I'm originally from the Washington, D.C. area. I do have a background in science. However, that's not why I was here, because I'm actually a baker now that teaches, that still does a little bit of research. I was diagnosed with celiac disease in 2016. And from that point, I guess the scientist in me kicked into full gear, and I had to figure out a way to recreate happiness as best as I could. And in the process, I developed my own custom flower blend to recreate happiness the best way possible, as well as minimize as many gut inflammations that I was having, specifically because in addition, I guess, to being diagnosed with celiac disease, I have a sensitivity now to rice flour and other grains and nightshades. I guess just depending on my level of stress and the level of food sensitivities I have. So that's pretty much been my journey, is that I love science, like absolutely, probably like live, breathe, eat, and everything science. So being diagnosed with celiac was actually like the perfect opportunity for me to like dive into a different aspect of science that I hadn't been in. That wasn't my formal background in science, but it just allowed me to like put the science hat on and figure things out.
And Nieshia is the origin of the yummy treats that are on your table. Gary, you can go ahead. Thank
Hello, I'm Gary Puckrein. I'm president of the National Minority Quality Forum. We are a research and education organization based in Washington, D.C. Most of our work has consisted around collecting health data, which we've been doing for about 20 years. We have a database of over 5 billion patient records. We collect data on about 160 million lives per year, covering well over 100,000 different conditions. We have been partnering with Beyond Celiac to build a celiac index, in which we are mapping celiac down to the zip code level and then aggregating it up to things like congressional district and state legislative districts.
Hi, everyone. I'm Martin Mendoza. I serve as the Director of Health Equity for the All of Us research program at the National Institutes of Health. I'm sure everybody knows NIH, so I'm not going to explain that. For those of you not familiar with All of Us, the All of Us research program is a cornerstone of the Precision Medicine Initiative started by President Obama in, I think, 2015. And its effort is to enroll 1 million folks across the U.S. that reflect the diversity of the United States. As folks know, too often medical research doesn't benefit everyone because folks, for whatever reason, are not included. And so our goal is to change that by including everyone, and hence the title, All of Us.
Thanks, Martin. Dennis?
Good afternoon, everyone. So I would like to call myself your friendly neighborhood pediatric gastroenterologist. So I am a gastroenterologist in Boston. I practice at the Boston Children's Hospital, and I'm also faculty at Harvard Medical School. Now at the Children's Hospital, I have the privilege of working with our trainees and in part being able to address a passion of mine, which is workforce diversity. You know, we know that when there are providers who have concordance, similarities with the populations that are particularly underserved, that they have potentially a unique insight to be able to address some of those prevailing health issues, those problems. But there's the issue on training enough individuals from these populations. So at Boston Children's, I chair the Committee on Diversity, Recruitment, and Retention across our residency and fellowship programs. We have about 50. And I work on the same effort nationally with a nonprofit that I helped to found called Building the Next Generation of Academic Physicians. academic medicine, like institutions like Harvard Medical School, has an opportunity to train individuals to, who are curious, who have a particular interest in disease processes like conditions like celiac. And especially, again, with that concordance of people who come from the communities who maybe are not getting the right diagnoses, we are able to hopefully cultivate this next generation of people to think of ways to improve the outcomes, improve the diagnosis prevalence. So these are the things that I enjoy to do in addition to being your neighborhood-friendly gastroenterologist.
All right, thank you all for being here with us today. We really appreciate it. So before we begin with the questions, I just kind of want to set the stage for where research in diversity currently stands in celiac disease. So for a long time, celiac disease was thought to be primarily a childhood disease, and it wasn't really known that you could develop it later in life. And then now it's often kind of seen as a disease that primarily affects people of Caucasian descent. And while data from NHANES and other studies suggest that celiac disease is potentially more common in whites than non-whites, it is not only happening in white populations, and diagnostic guidelines suggest that anyone presenting with symptoms should be screened regardless of race. However, research of clinical practice suggests that there are racial disparities in receiving a proper diagnosis of celiac disease. A 2021 Digestive Diseases and Sciences articles examined whether patients at one medical center received appropriate follow-up care when presenting with iron deficiency, anemia, and chronic diarrhea, which are common celiac disease symptoms. The authors found that Black people and those on Medicaid and Medicare had about 90% decreased odds of having the appropriate follow-up compared to whites and those with private insurance. Similarly, a 2012 study found that Black patients with diarrhea, anemia, iron deficiency, or weight loss were less likely to receive a duodenal biopsy compared to younger people, women, and white people. Recognizing the need for additional data, as Gary mentioned, we have partnered with the National Minority Quality Forum to examine and address health inequities in the diagnosis and treatment of celiac disease. Together, we're investigating the extent of undiagnosed celiac disease, particularly in non-white populations, through analysis of Medicare and Medicaid data. We will present an abstract with our initial findings at Digestive Disease Week in May, with more findings to come in the future. In terms of clinical trial participation in celiac disease, most celiac disease clinical trials published to date have over 95% white participants, sometimes only white participants. And we know that trials need to include diverse participants to make sure that treatments work for people of all races and ethnicities when they are finally brought to market. But no one can participate in a celiac disease clinical trial without first being diagnosed. So it's clear that there's a lot of work to be done in many different facets of this. One of our themes for this summit is partnerships. We know we can't get anywhere alone, and we hope that today we can all learn from our panelists and our stakeholders in the audience. And we want to work together with partners both within and outside of the celiac disease community to decrease inequities in diagnosis, management, and research. So I'd like to begin with Nieshia. Nieshia, you mentioned that you were diagnosed in 2016. Can you tell us a little bit about what was happening before then that led to your diagnosis? Were you having symptoms? How long had that been going on? That kind of thing.
Well, I've probably been having symptoms since I was like a young child because I had very poor attendance, probably throughout grade school because I always had rashy skin, like suffer from eczema and psoriasis, chronic migraines from like age 7, and was going to like specialists like my whole life. But it wasn't until basically in 2016, kind of like every autoimmune, it seemed to arrive. Like my joints were swollen, so they thought I had rheumatoid, so they tested for that. My stomach was distended. I had a lesion, and since being an African-American female, they thought I had lupus. Then the doctor thought it could have been thyroid disease, and they kept testing for everything, and everything came up negative, but the only thing that was coming up positive that there was an autoimmune present. And then there was a black nurse who said, anyone test you for celiac? And I was like, no. And she just said, I think I want to run that test because she had it. Because I was like, why? She said, because I have it myself. And then when she did the test, it came back positive. And then, like, life opened up for me. Like, it didn't take me an hour to get ready in the morning and be on antihistamines all year round just to stop itching. And just everything that I've been suffering from like a young child, just probably within like 3 weeks, life was great. Except for the fact that I couldn't eat gluten. And I mean, that's the biggest thing, because I'm the first to let you know, like, even though, I can recreate happiness, there's just certain things you just cannot recreate with wheat. And that is the biggest thing, is being on a strict gluten-free diet. But yeah, no one, the other doctors, but just to say that, like, no one ever thought about it. And even myself, even being from a science background, never thought of celiac because of the fact of my color. Like, most of the doctors, it never even dawned on them to even test me to see. They just were running. They were just like, oh, just come back, we do some more blood work, see if we can figure out this autoimmune that you have.
So if you hadn't run into this one nurse who happened to also have celiac disease herself, you might still be
probably going around the merry-go-round. That said, even with my own scientific background, I never even thought that celiac was a possibility.
Yeah. Well, we know we've heard this kind of story from a lot of different people. I wish, that we weren't hearing this story, but it's unfortunately common that people aren't tested just because of their race. Gary, we know that healthcare disparities exist in a lot of different forms, and NMQF is doing work in zip code analysis and indexes like the Celiac Disease Index. Can you talk a little bit more about that work and how it can start to illustrate the disparities that we hear about on a patient-by-patient level, but shows us a bigger picture of what's going on?
Yeah, I've been living in health data now for 20 years, and two things really strike me living in the data. One is that really our healthcare system is about reducing patient risk. That is its purpose, keeping people out of the hospital, keeping them out of the emergency room, keeping them from disabilities, keeping them from dying, and that is a data-driven activity. You have to use data to understand, particularly at the population level. It's incredibly important to do that. With minority populations, our community has been so underserved. I sit with folks who have multiple sclerosis, and people didn't think that African Americans had multiple sclerosis, and weren't diagnosing them for multiple sclerosis. And so it's not unusual with celiac that we're getting diagnosed late or not getting diagnosed at all. What's incredibly important, though, is to understand, at least from my vantage point, is to understand the geography of where these diseases are presenting, because we use that geography to then go into practices. So at some point, we'll have that geography of celiac, and we'll know the physicians who are treating patients in those communities, and there comes the opportunity to go into those practices to do quality improvement, to talk to them and help them understand the symptoms of celiac, and help them to understand that they can screen their patients and provide a better quality of medicine for them. And so that's really one of the important ways in which we use the data, is to help clinicians understand. You have to understand American history and American medicine to understand what's been happening in minority communities as it relates to chronic diseases or disease, period. That we didn't have the infrastructure. People forget that America was segregated really up until the 1970s. The American Medical Association, although they've apologized, was segregated so that physicians didn't get trained on on new science, and it came late into minority communities. Everyone talks about real-world data today, but the way medicine was treated for African Americans, because they weren't in clinical trials, was real-world data. It was after the medicine came to market. Those who served minority populations between themselves tried to figure out whether that particular medicine was efficacious and safe for minority populations. That's how medicine was practiced in minority communities. Everybody talks about real-world data as if it's something new, but in the minority community, that's exactly what was going on in order to do that. So I'm not surprised that we wake up and we find that celiac is being underdiagnosed in minority communities, that the physicians who are in those communities really haven't been approached to help them understand. A large percentage of the African American populations in states like Alabama and Mississippi, and I don't have to tell you, you can guess kind of the medicine challenges that are there. So anyway, we think using the data can open up the door and turn it into a data-driven exercise, because it's always about risk, and the only way you can understand the risk is really by the numbers, and so that's what we try to do at the National Minority Quality Forum.
Thanks, Gary. Martin, can you talk a little bit about the goal of the All of Us study and the data the NIH is collecting in this study?
Yep, happy to. So as I mentioned earlier, All of Us, it's an effort to enroll at least 1 million folks that reflect the diversity of the U.S. And as I also stated, oftentimes, underrepresented communities, they don't participate in research for whatever reason. And so, as Gary was just talking about, they don't benefit from those medical breakthroughs. And so what this program is looking to do is really to change that, to include everybody. We want to include everyone, so all of us. And so right now, we have enrolled approximately, consented, and folks have completed the basic steps of the program, about 320,000 people across the United States. Remember, our goal is 1 million. Of those 320 plus thousand, about 50% are from racial and ethnic minorities, and 80% are from what we call underrepresented biomedical research. So in addition to racial and ethnic minorities, this includes folks like sexual and gender minorities. It includes folks that live in rural areas, people with disabilities, those with poor access to healthcare. So really a whole swath of those that have been underrepresented in biomedical research. And then additionally, we have what we call our researcher workbench, which is where scientists can access that data and start to analyze and mine it. So right now we have about 1,500 folks registered on the workbench with over 1,000 research projects that are actively going on. One of the really cool things about All of Us is that if you choose to join, you decide what level of data you want to share with the program. So you have the option to link your electronic health records, you can link your Fitbit data, you can donate a biosample, so blood, urine, saliva. You can have take physical measurements like your blood pressure, your weight, your height, and of course you can, we send out periodic surveys focused on various aspects such as social determinants of health. And so you can choose to do all of them, none of them, some of them. It's really your choice how much data you want to share with the program. And so really what we're looking to do is to power research that accelerates health research and these medical breakthroughs to really enable to really enable the promise of precision medicine.
Great, thank you. Dennis, you do some work in healthcare workforce diversity. Can you talk about how that interplays? You touched on this a little bit in your introduction, but how that interplays with health inequalities that we see?
No, thank you, and I'm happy to expand on that because I think it's one of the critical remaining problems that we have to address in healthcare is who's at the table, who is there at the front lines to really engage the communities, especially those who have not been engaged historically. Now, there are those who have been underrepresented in medicine, there are those marginalized communities, and there are individuals who right now lead trials, run departments, whose priorities are not necessarily having those populations top of mind. And that is not really saying that speaks poorly about them and some, nefarious desires on their part, but rather there are blind spots. And we need to try to address these blind spots because we know that there are real-world consequences. It's not diversifying the workforce for the sake of it looking better. There are consequences of people's health. People can die. And that's, these are the stakes that we're working with. You mentioned a study that had the prevalence of people, the study really speaks to African Americans, but speaking about when individuals presented with the same symptoms of the iron deficiency and diarrhea, and they even had the proper workup, including an EGD, but you're in there, and then nearly 90% less likelihood of getting an actual biopsy with the same presentation. I mean, that speaks to an issue of how you were probably trained. This is why my focus has been on academic medicine and trying to think about who will be the ones training our future physicians, because there are disease scripts that people learn. That for those who are not aware, a disease script is we see patients, we have to see them at a pretty quick clip because of how reimbursements work now. So you really have to take certain shortcuts at times to think about how do I put them in this bin versus that bin. And these disease scripts of this is what that type of disease process looks like, this is the type of patient this looks like, gets us into trouble. So we've had to rethink how do we train our trainees around avoiding some of these biases, some of these blind spots. And those who have those types of topics top of mind are often people who come from those groups that have borne the brunt of those types of oversights. So that's why really assuring that we have a more representative workforce is important. And doing that is a large task. We have to go back all the way to primary and secondary education, to be honest, to make sure that that workforce pool is supported. But that's how we connect the dots there. There are real-world consequences, and those consequences can be dire.
What kind of work is being done in this space right now? I know you said you have a nonprofit that you founded, but is there, are there other kind of more, or in addition, systemic is the word, broad, I guess, efforts?
You would think that I've set her up, but I did not give her these questions. But this is part of the excitement in the last couple years in particular, that this has been seen, there's been the clarion call that this is something we have to address. So there are smart people who are trying to come up with systematic changes that we can implement. So there are new curricula that have been created and are being validated. It's coming up in journals every week, it seems. Someone trying to create some new approach to address, well, first recognize that you have bias, and then how do you mitigate that bias when encountering a patient? And again, these biases are not the biases of, oh, I think this person is bad, but the bias might be celiac looks like, a Caucasian female, which is not what the data truly supports, and we're learning more about this. So curricular changes are occurring. There's my organization, but also another one that I did not mention is NASPGHAN. So the North American Society for Pediatric Gastroenterologists, Hepatologists, and Nutritionists. This is the large body for pediatric GI that really tells us how we should practice, has created a subcommittee now, part of which I helped to lead, on diversity. And we're creating professional development curricula similarly to train those of us who've already gone through education, to train providers on how do we hopefully mitigate some of these problems. So addressing it throughout the pipeline, throughout the training process, are things that are happening nationally, and we're trying to make lasting systemic changes as opposed to one-time interventions.
That seems to play in well, Gary, with the work that NMQF is doing, because until we understand what is being underdiagnosed and in which populations, how do we begin to correct it so that physicians don't learn about only one specific presentation of celiac disease. Gary, can you talk about other ways that the NMQF is working with or is working to overcome barriers that are creating healthcare disparities?
So, I always hesitate to present the data this way when the physician's at the table, but he'll excuse me for doing it this way. So when people get ill, they go shopping, essentially. They go shopping in a pharmacy, they go shopping in a physician's office, they go shopping in a clinic, they go shopping in a hospital. So the health data we collect is really the footprint that they left behind. What were they diagnosed with? So that's in the record. What were they treated with? That's in the record. What were their outcomes? That's in the record. Did they come back? That's in the record. Were they given a different sort of test? And so you can do what we call look-back studies. You can look back to see how long did it take before that patient was actually diagnosed with the condition that was really confronting them. And so when we look at something like celiac, you can actually go into those states and communities and zip codes and understand what happened over time. Sometimes, sometimes it takes years for a patient to get adequately diagnosed. And oftentimes you find that somebody in the practice saw the disease somewhere and gave the hint, as opposed to it being in the clinical guidelines and the physician having to be educated. So what we try to do is we try to understand where did people go shopping, what were their outcomes, and as we come to understand that, then we partner with clinicians who can go into practices and say, we've seen this pattern, and maybe if we look at the guidelines this way, you can probably get a different kind of outcome for some of your patients. So when we say data-driven, that's really what we're talking about, is really understanding in the aggregate what's happening to patients over time. And certainly what we hope is that when we look at celiac, we're going to find a pattern, a trend in which people are not getting diagnosed. It's not one-off. It's a pattern and a trend. And if we can identify that, then there's the opportunity to do the quality improvement and other things that hopefully will bring about some change. And I would just add to that, one way forward is also to get people in clinical trials right now, to get those trials diverse, because the clinical guidelines are based on the clinical trials. And so if your clinical trials are not diverse, your guidelines are not going to be diverse, and we're going to continue to have this problem. So the front door is really getting those randomized clinical trials diverse.
That's a good segue. Martin, can you talk about some strategies that All of Us has used to reach communities that often historically have not been included in research or have been underrepresented in research?
Yeah, happy to. So what we've really done is we've developed this engagement ecosystem, if you will, and we like to say that it's national in scale and it's local in focus. And so what we do is we partnered with strategic entities throughout communities, local communities, and these can be, often things like faith leaders and people like these, people that are trusted voices throughout the community. And so we make these strategic partnerships, to reach out to specific communities. So for instance, we have a partnership with the American Association of Health and Disabilities to target those folks with disabilities. We have partnerships with the American Association for Rural Health. I believe I'm probably butchering their name, but the point is we have a specific partnership to target those in the rural community. And so by using these strategic partnerships, we're really trying to make our cohort as diverse as possible by really trying to meet people where they are is really the name of the game here. That
makes sense. Nieshia, unique patient in that you have quite the science background. So you know more about research than maybe the average patient does. But can you tell us, if you were thinking about participating in a clinical trial, where would you want to learn more? Would it be from your gastroenterologist you're currently seeing, if you're currently seeing one? Would it be from somewhere else? Where would you look for kind of trusted sources of information?
So I guess that's the paradox with me. I never even considered myself for clinical trials. Like, I have zeroed in other aspects of the disparities of minority health, and actually that's in a way how I got into science, like figuring out really from the academic perspective as far as retraining and rethinking, but not even for myself for clinical trials. I just try to figure it out myself. And just
That's
the
fair.
research and trying to put it together, but never actually putting myself out there, but just looking, at whatever, digging through different journals and articles and seeing what's going on, and just monitoring myself, but never putting myself out there. But I'm quick to give advice, like, oh, you should do this. They need to have that, or we need to retrain. And I'm always talking to my friends from school that are now professors, and they're like, okay, this is where I see what the problem is. You need to do this, you need to do that, but not myself.
That's definitely fair. Let's see. I think I'll ask one more question, and then we'll open it up to the audience. Dennis, what do you see in your clinical practice, and how you can reach who's coming to Boston Children's, who's presenting with celiac disease or other GI diseases, and is there an effort at Boston Children's in celiac disease to try to reach out to a more diverse audience? I realize that you're limited in who's coming to see you based on who's gotten referred to a pediatric gastroenterologist. You don't get your pick of reaching out.
Well, at Children's, we receive so many referrals on any number of sometimes very vague symptoms. And then there are the specific celiac disease, did the screen, and now you're being referred to Children's. And, the diversity of that referral pool is one that, as a hospital, we are trying to better understand. I know that we have efforts to try to understand. We generally know the high referring physicians in the community, but there are certain communities where we don't receive referrals from as often. And the question that on the QI side at our hospital is this because of a concern around Children's doesn't take our insurance? Is it because there's a distrust among parts of our local community? We do know anecdotally that there have been some historic areas of distrust with the neighborhood that's directly beside the hospital that is very black and brown, but have preferred to get their care at one of our other neighboring institutions. And this isn't something that on the primary care side of things, we've really been trying to engage the community to better understand why. There are some decades-long mistrust things going back to the busing experience in Boston, but there may be some other more contemporary things that we are not addressing. So we try to understand that referral base because we, one, think that we're the best place to get care. Certainly we're biased. There's, of course, a financial component to losing out on referrals, but also just the right thing to do. What is it that we need to be doing better with? Because we wish to remain number one. We want to be number one in the country, but also number one in our neighborhood. So that's something that I've been in conversations with some of the higher ups in the hospital around trying to understand, and that I would say would translate to the same referral base that comes to our celiac clinic. So with that as part of the answer, what are we doing about it? Not only researching it, but from my end, also making sure that when patients do come to us, that the providers, especially the trainees, are seeing them as a whole person, not being blinded by disease scripts and hopefully giving them excellent care. So that's the best answer I can give to you. We're doing work, we have a long ways to go, but at least we're trying to better understand some of that disparate referral piece.
Yeah, you're collecting the data, which is
Early days.
Yeah. All right, we can move on to audience questions. Oh, we're already set.
So I have a comment and a question. My first comment is that most of you probably know that in the late 90s, we embarked this massive search for celiac disease in the United States that translated in a paper that planted the flag celiac disease in the US soil, 15,000 people screened. Now, I really need an honest answer from all of you by showing hands. How many of you guys know that the outcome of that paper was the prevalence of celiac disease in the United States to be 1 in 133? How many of you know that the outcome of that paper also showed that the prevalence among African Americans was 1 in 300? Honest. Did I make my point? In the discussion, we forcefully put the message out there that celiac disease was frequent in the United States and was not a premise of Caucasians. The first message took, life, took time, but eventually nobody will say that celiac disease is rare in the United States now, as they were saying in 2003. We still have way to go to say this is not a premise of Caucasians. Now, my question, we have, of course, several patients. We see a fair amount of patients, both adults and kids, in our center. And we have, it's not huge, but a sizable number of minorities. And if we ask them, we have ongoing trials, you want to participate, the level of acceptance, and you just heard, is almost zero. Why? I don't trust you. And they have all the rights to don't trust us, because historically, the African American community and minorities in general have been used as guinea pigs doing unspeakable clinical trials that thankfully you can't do that anymore, because otherwise you go in jail and the key will be thrown away. But how we change that? What do you guys think that will take to change that? My son-in-law, a very educated African American man, said, I want somebody from my community involved, not you. Is that the answer? If not, what else?
So I can answer that question from the National Minority Quality Forum perspective. It started with an article that we did with Janet Woodcock, I guess it was last summer. And the idea was to train community clinicians to be PIs, because a lot of clinical trials in this country, if you go do the numbers, are happening in very specific zip codes around the country, and they're really not diverse in terms of geography. And so if you want to diversify your clinical trials, you need to go where the patients are. And community clinicians have the patients. Their practices are overwhelmed because of the way in which it was interesting. You heard that doctors are on a clock now. They got to roll patients out. That's a whole nother discussion that we ought to have. But the point is, at the community level, their patient panel could be 5,000 or 6,000 patients, right? And the patient panel should be around 2,000, maybe 3,000. So you get the point of why it's difficult for them to do clinical trials. So what we've decided to do, we've launched a program called the Alliance for Representative Clinical Trials. And in it, we are training community clinicians to be principal investigators. But beyond training them, we're putting trial coordinators in their practice, because they don't have the staff or the time to do clinical trials. And then we create a hub around them so we can do the administrative backbone. And we've partnered with PPD, with a contract research organization, to help them so that, because what happens is if you set up a trial, sponsors won't go to clinical naive trial sites for all the right reasons. And so in order to overcome that, we've partnered with a contract research organization that can hold their hands as they become more proficient in doing clinical trials. But we have to get clinical trials into diverse populations. Organizations like federally qualified health clinics, physicians in private practice, they have the patients and they have the trust of the patients. The FQHCs, for example, 50% of their board is from the community. And so you can break down those barriers by putting the structure in place. And so, that's what we're doing, and we've been fortunate to be able to get support because there's a general recognition now that we have to diversify our clinical trials and we have to put structure in place. And so that is really what NMQF has been working on.
And I'll just add to what Gary is saying. So, in addition to going where the patients are, there can't be the mindset. I'm not saying anyone has this mindset, but it just can't be, if you build it, they will come. That can't happen. So, as Gary was talking about, you must partner with the trusted voices in the community. So the clergy, the local pharmacists, the local clinicians, if you can, draw them into your study, have them, play a role in your study. But also, when you want, as I used to work at the FDA, I can tell you that the sponsors that we saw that were most productive at enrolling the diverse populations were those that before the first patient was even enrolled, they engaged in the community to build those relationships first. They went to the local community health fairs. They talked with the local pharmacist, the local doctor. And so they built those relationships, and they let those folks be their sort of conduit to the patient population. So then when it came time to enroll, those relationships were already there, and it didn't come as a surprise. And then after the trial is over, very, very important to keep engaged with the community, return the results to the patients. We don't just, patients aren't just looking for folks to come in and sort of be like one and done. We used you, we got your data, now we're out. And so next time they come, patients can be like, I don't want to participate. You just got up and left me. And so situations like that can really break trust. So keeping engaged with the community and having a really robust plan for return of results and continued engagement is one way to really ensure diverse participation of these communities.
I would just add to that, because I think it's important, particularly for this organization. Think of yourself as a learning community. And so as you're reaching out to get, hopefully, clinical trials diverse, you want to create those connections in the community, sustained connections, because the real idea here is to link research and bedside together, bench and bedside together, and the patient advocacy groups are the best ones to make that connection and keep that connection alive so that the information is constantly flowing and we're getting smarter and smarter and smarter. We have to accelerate the learning process, and organizations like this are absolutely important in doing that. We're learning too slow. We have to learn quicker. And the way to do that is to build learning communities. There's a great article that was done maybe about 2007. It was called Disease Networks, and cystic fibrosis is one of those that actually did it. I mean, that's what helped with cystic fibrosis. And so there's an important lesson from the cystic fibrosis community that this organization should pay attention to, because that's the future. The future is to build learning communities so that we're all engaged in tackling these diseases that confront us. And so that would be my strongest recommendation to you.
I'll just like to piggyback. One of the things that I've noticed in the community, just in celiac and just in disease in general, when it comes to minority communities, is just actually talking to the patients about what's going on. And I know because doctors are on the clock is like very difficult. So it's like, it seems that the medical profession tends to like push pharmaceuticals, and that tends to be like one of the first, I would say, like barriers to trust. That as soon as someone comes in, a prime example, I would say just all the way back to like the elementary school level, tends to be like in the minority community, especially when you go into public schools, every young black boy is diagnosed with ADHD. And most of the time, it's probably just malnutrition because they're coming to school with red Kool-Aid and a honey bun as their breakfast. So 9 out of 10, the irritability that you see, the lack of concentration is due to poor diet. But the teachers are quick to be like, ADHD, everyone's ADHD, but not really looking at the totality of the picture. And that just extrapolates to just other things. If you have high blood pressure or different things that tend to be very prevalent in areas of low socioeconomic status, that tends to be color driven as well. That is a lot of other things going on, and physicians don't discuss that to figure it out before just pushing a pill. So when that discussion that can possibly occur, I don't know, because the medical economics that can help or assist in the trust and to get into clinical trials, because it's like you're actually interested in the patient versus it's just this, just that, and that's what a lot of persons in the community feel. So it's like, what's the purpose of a clinical trial? Because you're probably just going to give me a pill anyway to solve the problem, as opposed to getting to the root cause of things.
As we pass along the mic, I do have a quick comment, 60 seconds here. But one, this again goes towards who are the providers that are engaging these communities. There cannot be assumed implicit trust. And also, we talked about a learning community. That is, I think, a message that we should take very seriously. The learning also is coming from the patient and understanding more about why you may have some reservations, because there's a grounding to that. The mistrust has been earned. I would recommend everyone read Medical Apartheid by Harriet Washington, if you haven't read that one, just to see some of the history in the US around minority groups and clinical trials. But even if these families haven't read that book or are familiar with Tuskegee and these other classic cases, there's often a very personal experience that they or other members of their family have had that turned them off. But you can't assume that they just won't want to listen, they're stubborn, they're just not compliant. Better understanding these communities is so important. And if it's not a concordant provider, have your research coordinator spend more time than we can have time with to learn from them why you're reluctant, why you're hesitant, and hopefully we can meet them. But we should just approach this a little bit differently than how we've done in the past, because obviously the past has not been effective. But there's a question, if there's time.
Yeah, so Beyond Celiac doesn't actually have an office. We are completely remote, even after the pandemic is, after everybody goes back to in-person. And on the topic of building relationships, do you think that doing that in person is best, or is it still valuable to, engage in social forums over social media or with webinars or something like that?
So NMQF, I'm the only one in our office. We're completely virtual. So, the office doesn't mean much anymore, to be quite honest with you. We use a lot of different tools to communicate. We use social media. I think it's incredibly important to have a presence in social media, because that's how information is flowing, certainly in communities. But you also have to build those ties in community. If you're going to be a patient advocacy group, you can't do it from a distance. You can't do it from an armchair. You have to know the community, where people are at risk, and be there for them, and help build that real sustained trust. I think, it's a hands-on business, and so I think however you do it, that is the task, is to get in community, know the risk and know the circumstances, so that you can be a part of the solution. There's no way around that.
Great. Thank you, Gary. And thank you to all of our panelists for being here today. We really appreciate it.